Lights, camera, cameras, action, snap, snap, snap. Howdy y'all, it's Dr. Jeff Jarvis back with another protocol review module. This one is on a new protocol. This protocol is for atraumatic headache. Atraumatic headache, their head does not hurt because they got hit over the head with a 2x4. This is the migraine or the benign headache. I'm writing this protocol because we have evidence from a paper I might have written, that we do a really bad job of taking care of patients with headaches. People with headaches make up about 2 to 3% of EMS call volume, and we can do something for them to make them feel better. We probably should. So the key part of this is that there is a way to effectively manage these people that is in their best interest, and there is a way to hurt them, to do something that does not benefit them. And that's specifically what I want to do, is call out what not to do. So for patients with atraumatic headache, what we want to do overall is obviously treat them with respect like we always do. We want to do a focused history and physical exam focusing on a neurologic exam, and we're looking for specific red flags. These red flag symptoms are indicative of red flag diagnoses. In other words, these are the really bad diagnoses, the things that we want to catch. The vast majority of headaches are benign headaches, and they just need to feel better. The minority, though, are bad, and we need to be able to identify them. And I include a list of these red flag diagnoses in the pearls in the protocol. Now, it turns out that I have done in the past a 2-part video that really goes into the assessment and pathophysiology of headache, what these red flag diagnoses are, and then the treatment of headache. And we're going to post that as an optional CE module. Those are not required, but if you want to know more about how to care for these people, how to assess them, that will be there available for you. All right, so what are the things that we can do for patients with headaches? Well, Tylenol, the same thing we would do at home. Don't forget that we do have the option, even as EMTs, to do something for these patients. So give them a gram of Tylenol. Cold compresses may help. Getting them in a cold, dark, quiet place can definitely help. If they're in a loud environment, dogs barking, kids yelling, husbands being husbandy, and all of those things, just try to create a little bit of a peaceful atmosphere for them. That can help with the headache. Now, if you suspect what is called a cluster headache, cluster headaches are headaches that occur typically in men and in, what could I say? That's right, clusters. In other words, they group up. You're having them daily for a week or a month, and then you don't have them. If you think it is a cluster headache, and one way to find out is say, sir, do you have cluster headaches? It's probably a good plan. If so, give them high flow oxygen, can be remarkably effective. If it's not a cluster headache, it's probably not going to help. Now, if you're an assist, consider ketorolac or Toradol. It is essentially an IV version of ibuprofen. Remember, if you think the patient has a head bleed, giving them an NSAID, bad idea, don't do that. The dose there, 15 milligrams IV or 30 milligrams IM. If they have nausea and vomiting and you want to address that, consider the nausea and vomiting protocol. And then here is a nice overlap between headache and nausea and vomiting. Droperidol is very effective for nausea and vomiting, but turns out is possibly the best drug I have ever administered for headaches. It's an amazing drug. We want to use a 1.25 milligram dose here. If you need to repeat it in 10 minutes, give it at 0.625. So that is the same dose as you would use for nausea and vomiting. Now, I mentioned that I wanted to write this protocol as much to say what not to do as what to do, and the thing that we should not be doing, according to every headache neurologist, every guideline for the management of headaches, is give opioids. No fentanyl, no morphine. Bad. Now, why is it bad? I think it's important to let you know this. It's not because the opioid doesn't help that headache. It will help that headache. If you have a horrible migraine, giving you 100 of fentanyl is likely to help that. If you happen to walk into an ER and get, say, 2 milligrams of Dilaudid, your headache is going to go away. maybe your breathing too, but your headache will definitely be gone. The reason we don't want to use opioids is because opioids, whether IV or oral, and this is a reason never to write a prescription for all of my physician colleagues for opioids, is because we know that opioids in treatment of headaches are associated with a decreased quality of life, decreased number of headache-free days, increased number of ED visits, increased number of ED admissions, so admissions from the emergency department because of intractable headaches. We know that it also increases the ED length of stay. These are all bad things, so we want to avoid them. And because you get these bounce back headaches, in other words, it helped this headache, but increased the likelihood of future headaches, it also increases the likelihood of opioid addiction. All of those things are, let me check my notes here. Yeah, bad. So let's not do that. Don't give opioids to a traumatic headache. If the person has a headache because they got hit in the head with a tire iron and their consciousness and airway is fine, yeah, fentanyl's fine for that. That is trauma. That's not the patient population we're talking about. Now, I do have another video that goes more in depth into the red flags. I'm just going to call a couple of them out here, specifically the bleeds. So subarachnoid hemorrhage or intercerebral hemorrhage, the key defining things that differentiate these from other headaches is sudden onset at maximal intensity and altered mental status, or I should say, or altered mental status. Most subarachnoids don't have altered mental status. You can have a little bitty one, hurts like hell, comes on like that. That's frequently called a thunderclap headache. Those are bad. We need to make sure that we get that bit of the history and relay that to the emergency department. Now, the other thing, sort of the classic description of a subarachnoid, is the headache comes on, again, sudden onset, maximal intensity with exertion. And if they have sudden onset of headache and syncope, boy, that is a subarachnoid until proven otherwise. We got to let people know that. Now, if you do think it's one of these red flags, and some of the other red flags include meningitis and giant cell arteritis or temporal arteritis, acute angle closure glaucoma, preeclampsia, got to think about preeclampsia, or carbon monoxide poisoning. If you think it's any of those things, that doesn't mean don't treat them. You can treat them. It just means be aware of this. And keep in mind, by the way, their response to treatment doesn't increase or decrease the likelihood of a bad cause. All right, guys, that is the headache protocol. That's what we do. Remember, no opioids. Treat them, Tylenol, Toradol, Droperidol. Wonderful things. Thanks a lot, y'all, and have a great day.